Everyone. My name is Dr. Jasmeka McCord. I am a second year neonatal perinatal medicine fellow at Emory University in Children's Healthcare of Atlanta. And I will be discussing with you all tiny beginnings, big conversations, science and skepticism in newborn care. This presentation is really important to me because as a pediatrician, I often have to discuss kind of some of the routine management of newborns with parents who have heard different things in the media about vaccines or vitamins or any type of preventive measures that we have in place that have been in practice for a long time. But the social media is changing and there's a lot of information, a lot of misinformation going on out there. So I wanted to really have a conversation and talk about why we do the things that we do, and hopefully steer some people from skepticism to trusting in the science. Um, a little bit about me. I'm from Fort Lauderdale, Florida, born and raised, lived throughout South Florida for the majority of my life, came over to Atlanta, Georgia to attend Spelman College. It's a shirt that I'm wearing today. It's reunion weekend and graduation weekend. And then returned back to Florida for my medical training that I completed at Florida State for medical school, Joe DiMaggio for residency, and am now back in Atlanta at Emory completing my NICU or neonatal intensive care unit training. I have a year left, so very excited about that and very excited to speak with you all. Speaking of Emory and my colleagues, I really wanted to shout them out, Dr. Aaron Bolin, Kristen Limpos, and Christy Sugimoto, who contributed to the slides that I will be presenting today. So without further ado, let's get started. These are my objectives for today. We want to essentially focus on hepatitis B, vitamin K, and safe sleep practices. There are so many things that we could discuss, but I really wanted to focus on these three because they're really related to mortality and preventing mortality, and they're very small things that we can do that can make a big impact. So we will be defining which newborns need vitamin K, differentiating between the different types of vitamin K deficient bleeding, describing parents' objections and concerns specifically as it relates to vitamin K and hepatitis B, exploring long-term effects on hepatitis B on infants, identifying the modes of transmission of hepatitis B and examining historical impact of the vaccine, and then transitioning lastly into discussing safe sleep practices. So it is Sunday brunch and you're with your best friends, and one of your best friends, her sister's pregnant, and so your friend tells you that her sister is talking about refusing the vitamin K shot because she's concerned it's not natural. So they ask you what's the real risk of vitamin K. So let's start off with talking about vitamin K. So what is a vitamin? Let's start there before we even talk about vitamin K. So we know that vitamins are essential cofactors to cellular functions and metabolisms, and they can't be synthesized by the body. Excuse me. So they must be ingested or administered, and they're often found in food or otherwise absorbed. Okay, so you can see here a picture of just the vitamin form or the tablet form, excuse me, of vitamin K that most are familiar with. So the K stands for coagulations vitamin. It's German root, I believe. So vitamin K is found in leafy vegetables. So that's your spinach, your collard, your kales, and are made by gut bacteria. So we all of us humans have bacteria in our gut. It's a part of our biome, excuse me. And these bacteria, these good bacteria produce vitamin K. Vitamin K is essential as a clotting factor for the factors that is essential, excuse me, as activating these clotting factors that you see listed here on the screen. What that means is that these clotting factors cannot function in their clotting abilities without vitamin K as a cofactor. Why is it important for clotting, right? Clotting prevents the onset of severe bleeding because your blood is able to clump together and stop bleeding from occurring. It's a process that is essential for survival for all of us as humans. Many might say, well, don't they get this from the placenta? All babies get whatever nutrition they need from the placenta, or don't they get this from mom's milk? And yes, the placental is a essential source of all types of nutrition for our babies in utero. However, there's minimal amount of vitamin K that crosses the placenta, and there's minimal amount of vitamin K that is present in breast milk, which is the number one recommended nutrition for babies. So through those two mechanisms, those main ways in which our babies transitioning from in utero life to extrauterine life, those are the main ways in which we provide that nutrition, and the babies do not get that vitamin K through those sources. So it's important. And what I want us all to remember, right, is that all newborns are deficient in vitamin K. Every single newborn, whether you're premature, whether you're full term, they're all deficient in vitamin K. And so the only difference is that for exclusively breastfed infants, these infants will remain at a high risk of vitamin K deficiency, whereas our babies who are fed formula will have a higher chance of repleting that deficiency over time through their diet alone, right? Because vitamin K is found in formula. So why do we care? Well, because of vitamin K deficient bleeding, as I already alluded to, right? And so vitamin K deficient bleeding was formerly known as hemorrhagic disease of the newborn. And what is happening here is bleeding, really as a source, as a result of not having enough vitamin K. And it occurs in three phases: early, classic, and late. In that early phase, it's within the first 48 hours of life. So, and in this, you might see severe, it's very, high mortality driven, and it is severe bleeding in the brain. Typically we see, and is often associated with maternal medications. The classic, from 2 days to 7 days of age, is essentially presenting with clinical bleeding and variable amounts of blood loss. This can be at the site of the umbilical cord where you have continuous bleeding. This can be from circumcision of our male babies who have that excise, that extra skin excised, and you can see endless bleeding from that. This can be from skin. You can see lots of abrasions on the skin, or not, excuse me, ecchymosis is what we refer to it as, but like kind of that lots of bruising is what I was looking for, bruising on the skin, or mucosal bleeding, right? And essentially how often we see that really varies based off of the resource, the settings of that specific environment. And then in the late form, which is from a week to up to 6 months of life, the is essentially presented with brain bleeds. You can see that 30 to 60% of cases present with brain bleeds. And even if these babies do survive, right, because there's a little bit of a decreased mortality in comparison to the early phase, but there is still morbidity as it relates to that. So mortality is death from a disease. Morbidity is whatever disease process that you might have to live with that may impact your quality of life, right? So up to 40% of survivors of vitamin K deficient bleeding survive with brain damage. And this chart here is really just a graphical or chart presentation of the information that we've already mentioned, right? So distinguishing the different types of the presentation is really time frame. So in that early time frame, you have the brain bleeds, you have the high incidence, and you have a high mortality. And again, this is all mostly in association with vitamin K deficiency. And then that classic period, you have other sites of bleeding, skin mucosal, and the mortality is quite variable. And then in that late time frame, it's mostly brain bleeds and GI bleeding as well. But the mortality is lower. However, the incidence of morbidity is higher. So from a historical perspective, vitamin K injection, right? So the shot was first used in Sweden in the 40s and recommended by the American Academy of Pediatrics in the 60s. And the recommendation has been IM, or injection shot administration, because it hangs around kind of in the muscle and soft tissue and distributes over time, really, really preventing that late onset of disease. So we know that vitamin K administration really eliminates late onset disease. There's a five-fold decrease in that classic middle period of vitamin K deficient bleeding. That's the 2 to 7 days, but decreases late vitamin K prevalence to almost zero, you guys, zero out of 100,000 live births. And that cannot be underscored, right? So we know that there are tons of babies who are saved per year from this late onset vitamin K deficient bleeding solely by administration of the vitamin K injection. It is not a vaccine, right? It is an injection of a vitamin, right? So this is clearly a good thing, right? So we know that still, despite us knowing this, there are more than 5% of parents who refuse the vitamin K shot and a 77% increase in the last 8 years. And I'm in practice can see that that number is steadily increasing. Why could that be? Well, there's a black box warning here, noted of a hypersensitivity reaction with IV and intramuscular use of vitamin K, which has caught the attention of the media. And again, anaphylaxis is something that I have not seen in association with this, but this has been released and has caused a lot of skepticism with our parents. What we do know, though, is that other common parent concerns are pain, of course, at the injection site, right? If the baby is new and fresh out and gets the shot and cries. In my experience, I will say that that crying that happens as an effect of the vitamin K really helps clear out any fluid, and really helps baby who may be working to breathe a little bit as they're transitioning into this outside world and having to breathe and take those first breaths really kind of helps with that, because they're exposing all of that fluid that's in their lungs or expelling, excuse me. Jaundice has been a parental concern, which has been associated with higher dosing in this outdated formulation that's been updated now. There's been distrust of ingredients and preservatives, and there is actually a preservative-free injection available. So that can be combated. And then in association with cancer was some that we saw in our in the studies preparing for this. And there was this was derived from the UK, some published literature in the 90s. However, studies that have been performed after that did not find this association. So there is an oral formulation of vitamin K, and everyone's like, why put the baby through the shot if they can have it? They do use this in Europe. It has to happen over a period of doses. And it must be given with food and not spit up, of course, right? Which we know if you've had a baby, you know that they are spitting up quite frequently. And so that is very difficult to control, right? And so that's one of the barriers to administering it that way, not knowing whether or not they truly got the vaccine or not. And in terms of the risk benefit, you want to make sure that this is effectively administered. But it is not currently approved in the US because it is, again, much less effective than the IM administration. Okay, in terms of the prevention of the late onset vitamin K deficient bleeding, you have more prevalence in the oral formulation than IM. And so, in summary, from a vitamin K standpoint, we know that it saves lives and prevents brain injury. We know that the IM dosing is safe and effective with a long track record, right? And we know that oral dosing is less effective and more prone to error, as we already mentioned, because of the spitting up and things that we can't control from a baby standpoint. However, if you were to try to truly decide, like if it was a matter of I'm not going to give it versus I am, we know that oral formulation is better than no prophylaxis at all. So that concludes the vitamin K portion of this discussion. So the next time a new parent wants to refuse the vitamin K shot, what will you say about that? Typically, I'd invite questions at this point in time. This is recorded, so we're going to jump right into our next discussion of hepatitis B. And so again, it's Sunday brunch with your best friends, and your best friend sister also mentioned to her that she and her partner have a clean infectious record, so they're not interested in administering the Hep B vaccine. Like, where's the baby going to get hepatitis B from? I don't see that that's even important. So, where could the baby get the hepatitis B from? So, let's talk about hepatitis B. So, historically, like before 1991, approximately 20,000 newborns annually, every year, were infected with hepatitis B. This is before routine vaccination. So along come in 1991, the introduction of the birth dose, which dramatically reduced hepatitis B transmission rates, excuse me, by over 90%, guys. So this is not fake news. We know that once the vaccine started being administered, that babies' lives were changed and saved. And then Fast forward over a decade, over a couple of decades, and only 13 reported cases of perinatal hepatitis B have been reported, highlighting the vaccine success. Now, this was in 2022. We know that since then, there has been much more skepticism about the hepatitis B vaccine. And then the safety consensus is that extensive studies confirm the vaccine safety and side effects are minimal. Okay, this is all data-driven information. So in addressing the common claims of the hepatitis B vaccine, so let's talk about the misconceptions and claims, right? Claims include a very low, this is where the science versus skepticism comes in this conversation. Claims include a very low infectious risk, inadequate safety testing, meaning it's low infectious risk without administering the vaccine. Inadequate safety testing, meaning, oh, we've been doing this and we don't know what's going to happen with the baby if we administer this. A link to autism, which has been reported in a number, or not reported, believed to be experienced once you administer a number of vaccines, and often citing vaccination policies in other countries, right? But the scientific evidence and the reality is that historically, infections risk were high, right? As we've already showed you. The vaccine is rigorously tested and safe. We have studies that show this with no autism link. One thing that I will say is that anecdotes are very powerful, right? I feel like many of us can say that we have heard of a situation in which a family member or a loved one or a stranger, someone who has, this has been told to us, has a child who got vaccinated and then became autistic or was found to have autism. We know that correlation is not causality. That's number one. So just because something might be correlated, meaning, oh, this happened and then this happened, that does not mean that that was the cause of that, right? Scientific processes are put in place to prove that something was the cause of something, right? And the studies that investigate vaccines as being the cause of autism are very clear that they do not cause autism. This is not to negate anyone's personal experiences. I'm a mother. If I definitely had a baby who got or was diagnosed with autism, and the only thing I can think of is they got vaccines, that was the only thing that was different, or I hear in the media people are saying it causes that, then of course I would have some type of skepticism as well. But there's our own personal fears, which are valid in that we feel them, but not valid in that the science proves that, right? And so I want us to move away from anecdotal, meaning I heard this person, that person say this, and look at the evidence that are massive amounts of studies that consist of lots of patients who are investigated to actually see if this is the cause of something, right? So I just want us to keep that in mind when we're thinking about whether or not we need to vaccinate our children or do anything, not just vaccines. We have to be careful about applying correlation theology to science because that is not clear evidence-based science. And I would recommend you following the American Academy of Pediatrics recommendations as it pertains to all things related to your childhood care. And I will get off of that soapbox and continue. But rounding this off, we know that the US healthcare context differs from other countries. We don't have enough time to go through that today, but you want to compare apples to apples. If we're comparing Europe and the US to Canada or wherever else, we know that, that's apples to oranges, and you want to make sure that you're providing comparisons in the context of what happens in this country, right? And so the challenges in the US, right? We know that the US lacks centralized healthcare systems found in countries like Denmark and the UK. So that prevents a barrier for us. And approximately 15% of mothers in the US are not tested for hepatitis B. And so you're putting a baby at risk by not administering this vaccine, right? And we're talking about risk versus benefit. By not administering, when a lot of women aren't even tested, you automatically increase the chances. Going back to those pre-1991 stats where the infection rates were higher, right? And of the hepatitis B positive cases, 50% were in moms who didn't receive the recommended HPV pregnancy screening, right? So a part of pregnancy screening is this infectious panel where you test for lots of different things, HIV, syphilis, all the things. And hepatitis B is typically one of them. But oftentimes we have babies who come in and there was limited prenatal care, and we have to do what we have to do to protect that baby in that moment, with the consent of the parent, of course. So understanding hepatitis B vaccine, virus, excuse me. So hepatitis B attacks the liver, hepatitis. So hepatology refers to the study of the liver. So hepatitis is inflammation, itis meaning inflammation, hep liver. So inflammation of the liver causes inflammation and potentially severe damage. So many infected adults can be asymptomatic and unknowingly transmit the virus. Okay, so that's from the most common or the most probable of, or not even probable. I'll just say that is the more traditional ways in which we can see this virus being shed from mother to baby or parent to baby. We know that babies have severe consequences in comparison to mature adults because they have immature immune systems. So they struggle to clear the virus. And we know that 90% of infected newborns develop chronic hepatitis B. So this is not something that's just acute. This is something that they will be dealing with for the rest of their lives. It leads to cirrhosis of the liver, where it's like scarred and severely damaged, and which leads to liver failure. And the liver is a super important organ. It really helps with the creation of clotting factors, cleansing your blood, all of these things. And so that could pose serious problems for a patient who is infected. And then there are higher rates of cancers associated with hepatitis B as well. So tragically, 25% of chronically infected children will die from complications as it relates to hepatitis. So this is not something that we can take lightly, and that's why we're so passionate about administering the vaccine for babies who are at risk. But there's that question that came up in the case, right? Your friend's like, I don't have hepatitis B. My partner doesn't have hepatitis B. Why my baby got the hepatitis B vaccine? Well, transmission pathways is important because it is not just via um, live transmission, vertical transmission from parent to baby, right? The hepatitis B vaccine virus, excuse me, survives on surfaces for up to a week. Up to a week. So that means if a person is infected, right, they got blood on your hands, microscopic, you guys, you might not see it, right? That's why hand washing is so important and surface washing. They touch the desk or the computer or anything, rusty anything, right? And that surface is not cleaned. That is, and these babies who put their hands in their mouths and all types of, this is how these things get transmitted to babies. They occur through microscopic amounts of infected blood. Bodily fluid also, saliva, tears, breast milk if contaminated can also transmit the virus, right? So infants can be exposed by any individual in their environment. This is just not just a mom dad thing, right? So that emphasizes the need for widespread awareness and vaccination, right? It's extremely important, and this virus is protective in the lifetime, as long as you proceed with the recommended doses from birth and on throughout childhood, it's protective, specifically for hepatitis B. There are a whole bunch of different types of other, as hepatitis A and C and all of those, but for hepatitis B, we have the ammo against it. And so in conclusion, from a hepatitis B standpoint, we know that the vaccine is safe and reliable, that does every individual in contact with the baby know their hepatitis B status? That's the other thing, right? We're talking about not just mama and daddy are handling the baby. You got grandparents and uncles and aunts who may not know, and they may be holding the baby, and you want to be as protective and as careful as you can, but there's no way to guarantee that a baby will not be infected. And so this vaccination is crucial. We already discussed that mom doesn't have to be a Hep B carrier for transmission to occur. And we know that babies are at high risk of chronic infections and complications and death from this. So when you are weighing the benefits of administering an injection or shot with your baby, right? The risk and the benefits. Autism is not linked to the hepatitis B vaccine, but even if it were, are you willing to risk autism over death, right? Are you willing to risk, if this were the case, which it is not, I emphasize again, are we willing to say, well, I'd rather my child die than receive autism? That's a question you have to ask for yourself. But it's not a relevant one when it comes to hepatitis B because we know that autism is not associated with administration of the vaccine. And the last thing we want to discuss, right? So Sunday breast brunch with your best friends again, and your best friend's sister is very excited to breastfeed. You go, girl. That is the most recommended nutrition. And sleep in the same bed as her baby while the baby feeds throughout the night. Pause. Is bed sharing safe and recommended? Let's transition over to safe sleep, guys. So you can't have a safe sleep discussion without talking about SIDS, or previously known as SIDS. It's now SUID, or sudden unexplained infant death, sudden unexplained unexpected death. Um, its previous language is now, whether it's explained or unexplained, it's unexpected, occurring in the infantile period, right? So SIDS cause assigned to infant deaths that can't be explained after a thorough case investigation, right? Including a death scene investigation, autopsy, review of the clinical history. So that meets the criteria of an SUID. Accidental suffocation or strangulation in bed, it's unexpected. That fits the criteria as well. And then unknown causes. And these are things that doctors are reporting on death certificates and death notes, right? And so all of these fit under the category of sudden unexplained infant death. Why does this happen? Why am I talking about this when we were just talking about breastfeeding your baby in the bed and sleeping with them? Well, because when you're talking about SIDS, there's like a trifecta of things that contribute to the increased risk of it. You have a vulnerable infant, right? You have this critical developmental period, all of these that interlace and overlap. And then you have exogenous stressors. And that is where we come in because we can modify the exogenous things that, such as the unsafe sleep environment. So that's why we want to talk about this here. It's extremely important for us to look at the trends in the SUID rates by cause of death, right? And so you have on this left side here, you have deaths per 100,000, right? So from 0 to 160 deaths per 100,000. And then these are the years in which we are examining, right? So from 1990 to 2022. So you can see that the deaths were and then looking at the different categories, right? So for the purple, we have accidental deaths and strangulation in bed, rising, 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 continuing to rise from the 90s on. Unknown causes are kind of variably all over the place, kind of slowly but steadily rising throughout this time frame as well. And then you have sudden infant death syndrome that here in the 90s were this rate and then has dropped significantly over time. And the same with the combined rates of all of these things kind of dropped significantly and have really stabilized out now. And as you can see towards the latter years, kind of more of a little bit on an uptrend. So what was in place during that time to contribute to the decrease in rates? The Back to Sleep campaign, which we'll talk about a little bit when we get a little bit more protective. But while we're talking about SIDS and SUIDs and the distribution of this, like talking about states, this graph is extremely important, right? Because the lighter in terms of like green, the better, you have lower rates of these deaths occurring in the light green areas. But when you get into that blue territory, that's when you're having rates exceeding of the 100 per 100,000 live births. Okay. And so where are we? Right here in Georgia, right in this 115 to 150 category. And we don't know how far off we are from that 151 in darker blue line, but it's not good, right? So, in terms of states and this is CDC rates from 2018 to 2022, we know that the rates are not where we need them to be. And these are all of the things this table kind of just discusses kind of some of the causes related to infant mortality, right? We know, and then the years as they've changed from then. So prematurity is one that is difficult to modify. Lots of studies and research and things going on, and that's why this is my field. This is where I am trying to work on Our babies who come earlier than expected. We know lack of oxygen to the fetus, essentially in utero, RDS. All of these are different things in relation to causes of mortality. And as you can see here, SIDS or sudden infant death, as we've been talking about, 11.7 in 2019, uptick, slow fall, back uptick, slow come down as of 2023. And so quite variable, and we know that there are things that we can do to impact this. But what about disparities? Are there disparities that exist amongst the babies who die from SIDS or SUIDs? And the answer is yes. So starting with the lowest risk of death by of death by race and ethnicity, starting with non-Hispanic Asian, lowest rates of SIDS here. I mean, near zero, 2017 to 2022. That's non-Hispanic Asian. For Hispanic, the next highest, non-Hispanic white is the next highest, and then invariably non-Hispanic. This is more than one race, so biracial in the purple line. And then we have the green line. They're kind of all over the place, overlapping. So, but as you follow me, the green line is non-Hispanic Native Hawaiian or other Pacific Islander. This orange line is non-Hispanic Black, and then non-Hispanic American Indian or Alaskan Native, so Native American, are amongst the highest to be impacted. So disparities definitely exist by race for sudden infant death syndrome. And then here you have it, is just the report from the AAP that kind of mentions the sleep-related infant deaths. These are the recommendations for reducing infant deaths in the sleep environment, and transitioning to a safe home sleep environment for the NICU patient, right? So these are kind of some of the studies that kind of guide our management and guide our recommendations. And so I wanted to pause here and just mention, this thought of bed sharing and co-sleeping. And we know that feeding a newborn is hard. They feed every 2 to 3 hours. They are hungry a lot, and it is exhausting. I've just been through this 2 times over now, breastfed both of my babies. And it is very hard. You are so exhausted, and of course, the easiest thing that you can do is have the baby right there next to you so that as soon as they cry, you're able to give them access to the breast, allow them to suckle and get the nutrition that they need throughout the night. But just because it's the easiest does not mean it's the safest, right? We want to make sure that we are protecting our babies from things that we know can be harmful, even though they seem harmless, right? Um, by far and large, we see that the babies who are at highest risk of sudden infant death or sudden unexpected infant death are babies who share beds. We want to share rooms. We do not want to share beds with our babies. And so, as hard as it is, I truly urge you all as parents who are trying so hard to provide adequate nutrition for their babies while being exhausted, is to really put the baby in a bassinet. It's called the Back to Sleep campaign, right? A baby should be on their back sleeping with nothing else in the crib. The baby doesn't need a pillow. The baby does, or in the bassinet. The baby doesn't need a pillow, doesn't need a bumper, doesn't need a binky or like any toys. The baby needs to be on their back in their sleep sack or in a swaddle, until they're able to roll, and then those recommendations change. But that is how a baby should be sleeping by themselves. Too many times we find babies who are bed sharing and co-sleeping with their parents, and you're exhausted, right? Or a mom or dad rolls over them, or they get caught because the bed is so soft, and you put them on their bellies, and a baby doesn't have the head strength to lift their head or move their head, and so they can suffocate even just by being on their belly if nothing is in the crib, right? And so these recommendations come from tragedies. We know that, right? We want to prevent tragedies. Prevention as a pediatrician is of the utmost importance for me. And so I just want to really send that as a take home point for back to sleep and doing what we need to do. So And this is just showing how babies are doing at home and the percentage of women who reported most often placing their infant to sleep on their back by demographics, right? And so overall, this is about a 73%, which needs to be 100. Like, there's no reason why this number shouldn't be 100 with the appropriate it doesn't cost anything. Like, put the baby on their back. And even if there are issues with getting cribs or bassinet, like there are programs that we can help with that. And so truly placing their babies on their infants, on their back, excuse me, to sleep, um, goes up higher with age, the incidence in which you see that. So about 70s percentage when they're greater than 35, maybe a little bit more experience under their belt. I don't know. I don't want to speculate. The highest in the white non-Hispanic population, lowest in the Black non-Hispanic population, which may account for some of the statistics that we previously just saw. And then a variable in Hispanic and other non-Hispanic populations. And then for insurance, by insurance, right? Because finances is something that is a cofactor or co-founder in care. Mostly insured privately placed patients and Medicaid patients have the lowest amount of adherence to placing their babies or reporting placing their babies on their back. And this is Georgia information, guys. So this is not, this can be, this it definitely can be extrapolated for our population that we are serving. And so really, in summary, while it's difficult, while it's challenging, it is extremely important nonetheless to put our babies on the back to sleep to make sure that we are taking the appropriate care and attention that is needed, especially during nighttime, but all throughout the day, backs to sleep, nothing in the crib, to give our babies the best chance at success. So in conclusion for this presentation, I just wanted to review the objectives that we discussed in the beginning of this presentation. We've spoken about vitamin K, we've spoken about hepatitis B, and we've spoken about safe sleep. And I really implore you all to use the evidence, right? If I could leave you with anything after this presentation, it's to make sure that you're doing your literature searches and feel empowered to talk about these things with your pediatricians. With your pediatricians, present the data to them, share your concerns. Hesitancy and skepticism are allowed, okay? But they should be validated with science, okay? I will always welcome my patients to ask questions, to present their concerns and fears, and your concerns and your fears are valid. But now we have to figure out how to address that, keep the baby as safe as comfortable, and keep our parents' mind at ease. So it's always my pleasure to present to you all. I thank you so much for your time and attention. If you have any questions, this is my email. I thank you so much.